Hello, my name is Michelle Morand. I'm a precision cancer medicine patient educator and advocate, and I'm about to share with you an interview that I held about a month ago with Gail Baron Simpson. She wanted to share her story of how she went from late stage 4 with no more options aside from palliative chemo to complete response in just a few months through the assistance of Alex Rolland at Cancer Treatment Options and Management and his team, personalized oncogenomics testing, research and advocacy service. What I really want you to understand before you dive into this interview, there's two main things. One, Gail's experience is not unique. It is the norm. It is what you can expect, even stage 4 patients can expect when you thoroughly apply the most current precision cancer medicine diagnostics and treatments to your case. I really want you to understand that it might sound fantastic. It is amazing and it is fantastic, but it is not unique. It is not the exception. And is the norm that patients are starting to be able to expect from the thorough and proper application of oncogenomics, personalized cancer research and advocacy. So it's one thing I want you to really know before you watch the interview. And the other thing I want you to just keep in mind is Gail's medical oncologist really had done the very best that he could for Gail prior to her coming to us, as most medical oncologists do. He had tried as many things as he had available to him and knew to try, and had really pulled out all the stops he had available to him. He just did not have all of the resources that science-based medical research and precision cancer medicine can apply. They're not part of standard of care just yet. So he did the best he could with the tools that he had to work with. And when Gail brought to him the information that we had helped collect for her about what treatments were going to knock it out of the park for her, he was willing to provide her with the prescription and do the follow-up monitoring to make sure the treatment was working as well as it possibly could. And he was just thrilled that in her first follow-up CT scan, she had a complete response to the medications that Alex and his team had identified. So watch and see how it all happened, how it all unfolded. Keep those two things in mind. The vast majority of the time, even when your doctor has said there are no more options for you, they will help you get on a medication you need when you provide them with the proper evidence about what that is. And Gail's experience is the new norm, not the exception.
It's a long journey, so it's coming up to 12 years. And it started like Christmas 2011. I wasn't feeling well. It took 6 months for diagnosis. And at 6 months, my tumor was the size of a watermelon by the time I got in for surgery. And then it was urgent surgery. By the time I met the surgical oncologist on July 5th of 2012, I had surgery on the 17th. So, once I got to the right person, it happened quickly. But yeah, the kind of dismissal you get at first, well, if you're not feeling well, if you're bloated, try eating more fiber, drinking more water, that kind of dismissive attitude. But you have to press on because it wasn't going away.
Right.
And eventually got results. And then part 2 of that was after a year, the oncologist cut me loose because she said, well, we've dealt with it. You've had surgery. She had 2 follow-up appointments with me and you're good to go. But granulosa cell tumor is a rare cancer, 3 to 5% of ovarian cancer, but 3% of that recurs. So I was the double rare recurring. In 2016, it came back.
Okay.
And I had to start again with a GP, right, referral, etc. I had to get back to the Cross Cancer Institute.
So how much time passed from the time your doctor said you're good, you're done, and then the recurrence?
3 years after she released me. So it was 4 years between surgeries. It's a slow growing cancer.
Okay.
especially at first. But once it takes off, she used the analogy, it's like blowing up a balloon. You know, at first it's really hard to get air in. And then once it starts to stretch, it goes quickly. So that's why by the time I had surgery, I had a watermelon to deal with.
Right.
And yeah, so yeah, it just starts, it takes off and then it's urgent.
All right. And how did you know that it was back after 3 years? Did you notice something, or was it a
Yeah.
routine follow-up scan, or?
Yeah, no, I started feeling the same bloated feeling that doesn't go away. You know, it's kind of vague, but you don't feel well. And I recognized the same symptoms from 4 years earlier.
What
And
was that?
so,
Tell
yeah, I
me.
had to start again with,
Yeah.
yeah, yeah,
It's like the internal, like the mental and emotional process of starting to notice those symptoms. What was that like?
hoping it wasn't true. Like, oh, I don't feel awful about it. So I started doing things like I would buy bags of dried ginger and chew on that. You know, I've always been this way, try to self-medicate, but you know, that's a holistic way, right? Try to deal with it. So any remedy that I tried, peppermint tea, etc., nothing worked.
Right.
And I'm thinking, no, I think the disease is back,
Yeah.
right? So
Kind
I
of test
tried,
it yourself.
yeah,
Let's try this natural thing that if it is something
yeah,
other would be helpful. This isn't,
yes.
damn it.
Yeah, so that went on for a couple of months, and then I got into my GP was on mat leave, so I saw a male doctor who was covering, who dismissed me as, you know, try drinking more water, eating more fiber.
Even with this history, they knew that you had.
Yes, yes, and so he literally could hardly wait to get out the door because I'm describing my symptoms, and he thought I was a complaining woman.
Oh,
Anyhow, it made me angry. And so then I called the clinic back and requested a female GP,
yeah.
and she took me seriously. Thank goodness. Yeah, sent me for a CT and like got things moving quickly because of my history.
Yeah.
So yeah, that was quite frustrating to be dealt with in that regard.
No.
Yeah.
Yeah.
Yeah, but anyhow, she got me on track, and as it turned out, my surgical oncologist was on that leave, but she came back. I was her first surgery when she returned in September. So by the end of the summer, I was having my second surgery, laparotomy. Then it started recurring faster. So that was 2016, then 2019. But by this point, I was having regular CT scans every 6 months, and she was monitoring. And, you know, then there comes a point when the tumors grow and she has to pull the trigger. And so then I had my third surgery in May of 2019, but instead of one tumor, I had 4 tumors. So it was multiplying. And the only treatments for granulosa cell tumor are hormone suppressors and surgery. And in the interim, I tried anastrozole and letrozole, and no result with both of them. So I had the letrozole injections for a year and anastrozole for 2 years, and no result. All along, she told me that she wouldn't put me through chemo because there was only a 10% response rate with my cancer.
Okay.
So, and also, I guess it didn't really change the outcome overall. So, that wasn't on the table. So we proceeded with the surgeries. And at one point I asked her if there was a limit, like how many surgeries can I have? And she said, well, she'd had a patient that was going in for her 10th laparotomy. I went, whoa, that's a lot.
That's both distressing and reassuring, I guess, right?
Yes, it was, because I thought, like, is there a limit? I had no idea what the
No, I would.
process was or what to expect.
Mhm.
And I found it's a matter of they only give you the information you request. Like, they don't give you a big picture. They don't explain the whole disease to you or anything. It was, if I asked a question, it was answered.
Yeah.
But if it didn't occur to me to ask, then I didn't know, which
Yeah.
is part of the problem, right? Because I didn't know if there were any alternative treatments or anything else to pursue. I was told this is what there is
Yeah.
in, you know, in traditional medicine. So,
So yeah, that's a really good point about how
yeah,
you don't know what you don't know.
exactly.
And they only tell you kind of what you're asking about, or kind of
Yes.
you know,
Yeah.
there's as you've discovered, and really what we're here to talk about is that Grand Canyon sized chasm between what you're informed of and what's possible, really.
Yes. And so all along I hadn't a clue there was any other alternatives. And then I had my fourth laparotomy last year in March 2022.
Mm-hmm.
And right after the day after the surgery, I was told that she'd wanted to remove my colon, but because we hadn't discussed it, she was going to schedule a separate surgery. And I thought, why didn't you just do it rather than two surgeries? But it's too late. And so then I had my colectomy end of May. So that was a lot last year. And after my colectomy, I was told that I would not be offered any more surgeries because there were some tumors that were inoperable,
Oh,
and I was done.
okay.
And she basically said I had a year to live. And I also had some tumors that had developed on my spine, T4 and T8.
Okay.
And as it turned out, that was just discovered when they were reviewing the CT scan before my surgery. And they grew quickly. And they were, by July, I was in excruciating pain. I
Mm.
had radiation therapy in August, and the tumors did shrink, but then my T8 vertebrae collapsed and T7 and 9 were fractured from the tumor. And I had to wait until the end of January for vertebroplasty, like it's a cement that they inject into the collapsed vertebrae. And so I was on morphine for 4.5 months to deal with that.
What was the delay? What was it?
Pardon?
Was the delay about our system, or was it
Yeah, it was a system. I had to wait 4.5 months to get in for vertebroplasty. And actually, I was originally scheduled for February, but there was a cancellation. They got me in January because I was told that this does not heal. Like it's not something that'll heal. They had to fix it.
Well,
So
imagine how
yeah,
just the pain of
yeah.
that, let alone how debilitating. I can't even imagine. Oh
Okay,
my.
so here's the upside to that, Michelle.
Okay. All right.
So now I'm sitting in my stressless chair in my living room for those 4 months with a heating pad. And at first I was on T4 and then on morphine. That gave me a lot of time to research, right? So I spent it wisely.
Use your time well. Yes.
I
Good.
did. I used my time, right? I had hours and hours of time to surf the internet and research my disease and possible alternative treatments, etc. And that's how I found CTOAM,
Mm,
right? Because I guess the algorithm of all my research, eventually you popped up.
wow. I'm
Because
glad.
again, I had no idea there was such an option. But I
No.
did along the way. So when I had my follow-up appointment with my oncologist in July of 2022, I'd already started researching because I was told I had a year to live. And I thought, oh, I had a neighbor who was on in a trial for Keytruda for uterine cancer, and it was successful. Like she's great, she's cancer free, and I thought, oh, I guess there are new alternatives and drugs and treatments, and that sparked my interest. I thought, if there are treatments for others, perhaps there's a treatment for me. And I thought, well, I'll even ask my oncologist if Keytruda is applicable for me. Apparently it's not, right? Because of my journey with Alex, I found that it isn't. But I also came across some other drugs that I asked my oncologist about. I asked about proton beam radiation and just anything that I could find that might be a possibility. And she did refer me to radiology. And as I was going for the radiation treatments for my spine, I did discuss that and was told, no, that's crazy. You can't have radiation because, first of all, you can damage your intestines because it's in my abdomen and pelvis. And so the analogy is, so the radiation beam goes in one side, but then is like a shotgun effect coming out the back and damages surrounding tissue.
Mm.
And intestines move and can easily be damaged. And
Mm.
anyhow, not an option
Right.
at that time, but it could be in the future for palliative treatment. So like I said, I did explore anything I came across, came up empty-handed, except interestingly, I did come across one of the drugs I came across in July 22 was nirogacestat, which was in international clinical trials in Italy and the US. And turns out that there's a clinical trial at the Cross Cancer Institute right now, which I was excluded from. I was on the list, but I was excluded from because my CT scan in mid-May, which is the week that they were screening for the trial, actually was a stable CT because I was on gefitinib. And it had to be progressive disease. But turns out I actually did have progressive disease because I had bone lucency, which is progression, but they didn't recognize that as progression. So mistakes are made along the way, but in the end, that's a positive mistake because I would have had to go off of gefitinib and I would not be on fulvestrant.
Right, exactly.
I'd be in this clinical trial.
Yeah, exactly.
Yeah.
And that's right. So so up to this point, has any sort of genetic testing been performed for you?
Nothing, no. And see, when I did ask about Keytruda, she said, oh, we do test for the PD-1, but that wasn't offered for me. And they did do genetic testing for one of the other drugs, and that also wasn't offered. And I know it's expensive, and I don't know what the criteria is
for the drug.
Well, no, for the testing with Alberta Health Services. I don't know, because now I would know to ask. But back then, this was all so new to me, and I'm just finding my way and trying to understand everything. And
today, 2023, if you were to ask, you would be told, we've already done that for you, and that would have been kind of a standard small inherited mutations panel, or it's not warranted in your case, or it's not necessary now, or whatever. It's not remarkably improved from 2011 or even 2019.
Yeah, on May 18th, when I discussed, so I had the scan, or sorry, May 13th, I had the scan on the 13th, and consequently I had a intestinal blockage the same day, so I wasn't doing well. But my oncologist called me to discuss the scan, and I printed it off and read it and discussed it with him, and he says, well, you're excluded due to disease stability. And I said, well, what about the bone lucency? And he says, well, I don't think that's progression, but we'll keep an eye on that. So
rather than thinking, how can I, as a doctor, present this data to help my patient have the greatest likelihood of getting on this trial, it's just, no, I'm not even going to lift a finger here, and not even going to try to make this work for you, even though it's possible it might be a fit.
Yeah, I'm not too upset about it, given where I'm at now.
Well, exactly. That's right. Yeah,
it worked out. Yeah.
It's for people, again, who are coming after you and who will see this and are trying to decide, how much should I just accept what my doctor tells me versus look a little bit deeper. This is a good example, or even with that one scan, of how sometimes these scan results are misinterpreted, and that can have profound effect on what you are offered or not offered, however inaccurate.
Yes, and so also in May, I had gone to Phoenix to pick up my gefitinib, and I thought, well, while I'm there, I'll go to the Mayo Clinic, and had a consult. First of all, with an oncological surgeon who offered to clean me out. She said, we do surgeries no one else will do, but we'll have to remove your bladder, and it'd be like a lot more recovery, more difficult. Everything would be worse. But the problem is it recurs. It's not a cure, right? So it's a temporary fix. And so I said no to that. So they referred me to a medical oncologist who said bone lucency is disease progression.
Yeah.
So anyhow,
that's
that part. But Alex is with us now. So
Hi.
Hey, Alex, welcome.
Hi. How are you doing, Gail?
I'm doing well, Alex. How are you?
Good. How are you feeling?
I'm feeling good. Like it's interesting since my fulvestrant injections, like even after the first round in September,
Yeah,
I mentioned to you that I was already having hip pain and lower back pain.
yeah,
And by the time I went for my radiology consult at the Cross,
yeah.
that had disappeared. So
Wonderful.
I am feeling better, right? And
Great.
now I've had 3 injections. Next week I
Okay.
go for my fourth.
Nice. Great.
Yeah, yeah.
Great. Wonderful.
So, Alex, maybe we could start for your piece of this dialogue. What would you like people to understand about Gail's case, and specifically information about her type of cancer, specifically what makes it unique, but also how some of the information specific to her is also relevant to ovarian cancer in general. And then maybe tell us a little bit about kind of your thoughts from your first consultation to today in terms of how this has gone.
Yeah. Well, I'm sure everyone knows that this type of cancer is really kind of what we call an orphan cancer. It's a germ cell tumor. So normal ovarian cancers are either high grade or low grade serous carcinomas. And so the germ cell tumors are actually very rare, as Gail, I'm sure, knows. And the problem with a cancer that's very rare is there's not a lot of data on it, and not a lot of protocols or information on it. And I knew as soon as I spoke with Gail that if we had a proper molecular workup, we would more than likely find some good targeted options. I didn't at the time understand how complicated those targeted options would be. The bizarre set of circumstances that led up to the particular combination of drugs she's on now. That's where things started out. Mm-hmm. So initially, we started with tumor DNA sequencing, and we found a few interesting things. But two things that really stuck out were two mutations in two different genes. One of them was a PIK3CA. It was called a H1047L, if I recall. That's a mutation that is actually found in lobular breast cancers. It's commonly found in lobular breast cancers. And it has a targeted drug called alpelisib. Now, the drug can have a lot of side effects, and it's a relatively new drug, but it's only approved for breast cancer right now. And it's kind of an expensive drug. So that was one drug that we thought would, definitely have an impact. But what we also found was a unique BRAF mutation. And BRAF was first really discovered and established in melanomas, of all things. Now, mutations are really classified on a variety of different components, more on how they actually cause the cancer. And that's really what we're interested in is what is the mechanism of this specific mutation versus others. So commonly, we'll get a BRAF mutation called a V600E. And what that means is the normal amino acid, the valine, at the 600 position has been converted into an E, which if I recall, is a glutamate. Don't quote me on it. I don't have all my amino acids memorized yet. But anyways, what that does is that causes that gene to stay stuck on in something called constitutive activation. And so there are there's some drugs that target that very well. Now, and that's what we call a class 1 BRAF mutation. It has this alteration. It changes the function of the protein, the gene, and causes it to stay stuck to its partner. So it's constantly signaling and constantly turned on. And that signaling tells the cell to constantly grow and copy itself. So both of these PIK3CA and BRAF are oncogenes. Now, Gail had a very unique BRAF mutation. It was called the K499E. K is a lysine, and the 499th position, it had been converted into an E amino acid. This is referred to as a class 2 BRAF mutation. And we had to do some research on this because we weren't sure, and there wasn't a lot of data on this mutation. And so we spent a substantial amount of time looking into the different mechanisms of the different BRAF mutations. And we found that in this particular mutation, what it does is it causes a process called dimerization. And what that means is two of these BRAF molecules will actually come together. And when they come together, they turn each other on. So you get this dual activation. And it requires both of these these two BRAF receptors coming together. Whereas in the BRAF V600E mutation, it's just one by itself, and it attaches to its signaling partner and turns it on that way. And so this dimerization actually makes that BRAF mutation resistant to all known BRAF inhibitors. So we knew we had a bit of a problem there. So we found out purely by accident a study, preclinical study, that basically said that because of this dimerization mechanism that is very unique to this mutation compared to other BRAF mutations, because of this dimerization process, there was a drug that targets a different receptor called the EGFR receptor. And this drug is called gefitinib. And it actually targets the dimerization process. And some studies have found that it targets the dimerization process, not just in this EGFR, but particularly in the BRAF class 2 variants. So we thought, wow, okay, well, let's give gefitinib a try, because it actually targets the molecular features of Gail's mutation. And I don't need to really get into germ cell tumors. They're very complex tumors. There's not a lot of protocols for them. It's typically treated with very harsh multiple chemo agents that are very old drugs, and they're not very effective. In fact, I think Gail, you were offered a 5% chance of the chemotherapy.
10, and then 10. They upped it to possibly 15%.
Okay. Yeah. So our research showed it was around between 5 and 10%. And definitely in the later stages. So
sorry, what was 5 to 10%?
The chance of the chemo being offered to Gail.
Okay.
Yeah, it's overall response rate.
Okay.
Yeah, so we thought, wow, well, you have a choice, Gail, of the chemo or this EGFR inhibitor, gefitinib, that really we're only basing it on a mechanism. We have no clinical data, no clinical trials, and to be honest, using an EGFR inhibitor on a BRAF gene has just never been done. So we thought, well, the drug doesn't have a lot of side effects. Let's give it a try. And so we were able to get, convince Gail's doctor to giving it a try, or Gail was able to convince her doctor, not us.
We're gonna circle back and talk all about that.
Yeah, he actually said it made no sense what I was asking.
Exactly.
He says that makes no sense.
And it made no sense to us either until we looked at the actual mechanisms. And this is the importance of really getting into the precision oncology and understanding the mechanisms of a mutation rather than just what it's supposed to do or what the drugs are designed to do. So
when you're talking about the mechanisms of a mutation, just tell us, just define that for us. What does that
mean? So the mechanism of a mutation is how it causes the cancer. What does it do? And in this particular case, as I mentioned previously, the normal mechanism of BRAF mutations is to stick to their partner and stay stuck, turned on. Whereas in this one, it actually causes activation by partnering with another copy of the BRAF mutation, and then they turn each other on. So it's kind of like a mutual dating thing for the BRAF. And because of the mechanism, drugs are designed specifically for a mechanism. So all of the BRAF inhibitors are designed to target the BRAF V600E mutation. They're called tyrosine kinase inhibitors, and they inhibit the tyrosine kinase domain of the gene to turn it off. In this particular case, the gefitinib has a completely different mechanism. It prevents these two BRAF altered genes from coming together and activating in that way. And so a normal BRAF inhibitor wouldn't have worked for Gail because of this unique mechanism of these class 2 BRAF mutations. So once Gail got on it, it became very clear that the drug was definitely stabilizing her cancer. And
I had a liquid DNA test after 30 days, and the level was down. What was it? The PIK3CA level, had decreased.
Yes.
So you knew within a month using a blood-based test, a liquid biopsy
for a different mutation, for her other driving mutation.
Yeah,
but you could see that it was that the drug was working, and that must have been some relief right there, just having a sense of that for sure. And
then feeling better, and then of course the scans. I think the scans showing stability and some shrinkage over a long period of time was quite exciting.
So I started the gefitinib February 14th, And by May 13th, I had the stable CT scan. Aside from the bone lucency, that was a progression, but what not recognized.
Yeah.
Okay.
And so your doctor is fairly excited about that.
Yes, yeah, he couldn't believe it. He phoned me.
Yeah.
He says, "Wow, I can't believe it."
Yeah, it's actually
So
working.
yeah, he
So
was.
then the next goal was to, okay, so if the gefitinib is working, we want to use it as long as it works. So let's get it for a cheaper price. And so we had our drug navigator come in and shop around for a different price. And so what most people don't understand is that cancer is an international disease, and there's many international pharmacies that compete and sell the same drug for different prices for a variety of different reasons. So you can get drugs at radically different prices depending on where you go to. And there's also, places like, Mark Cuban has a specialty oncology pharmacy where he offers, oncology drugs at a way discounted price. So Gail, how much were you paying for the drug?
Okay, at Shoppers Drug Mart,
Yeah.
$2,150 for 30 pills.
Okay.
Through Affordable Meds
Yeah.
in Florida, who ordered them the gefitinib from Turkey.
Yeah.
$300 for 30 pills.
Wow.
That's Canadian.
Yeah. So what a difference. What an amazing difference.
Yeah, thousands and thousands.
Thousands,
savings.
yeah. I know. So people are paying for these meds, and the doctors don't even know that they can get these meds from international pharmacies for a fraction of what they would pay at a local Canadian pharmacy.
Well,
Oh, I told my doctor.
It's actually a little worse than that, Alex. As somebody who works on the advocacy side, I can tell you that a significant number of Canadian medical oncologists believe that any drug that you get from an international pharmacy is substandard quality. I've even had them tell me that because they cannot guarantee the chemical compound of the drug, they won't prescribe it. Even, and as you're well aware, the same drug, it works perfectly well. It's coming from the same pharmaceutical company. It's the exact same drug. It's just that it's cheaper in other countries because our drug prices are so high. But that might be something, I'm just saying, not that you ran into, Gail, but anybody, watching or following along at home, it's actually almost better if you don't mention to your doctor that you might get it from an international pharmacy.
I was upfront with him about everything.
Yeah.
But one thing that did reassure me about acquiring this drug from Turkey, the Alberta government had ordered. Remember when children's Tylenol was in short supply last winter with
Yes,
flu
yeah.
season?
Yes.
And they had a contract with a pharmacy company in Turkey to supply Alberta with children's Tylenol. It was a generic brand, but and I thought, well, if the government of Alberta's vetted it, it should be good enough for me.
Yes, that's right.
That's great.
But that is a barrier that can arise for folks if they want to get the drugs, at lower prices. I mean, what a big difference! $21.50 versus $300.
Yes.
So just something to keep in mind. That international pharmacies are so much more affordable. It's the exact same drug, and that perhaps a public health care oncologist might not understand this and may have a bias against them. So
you have to travel to the US to pick it up, though. We can't ship it to Canada. That's illegal.
Right.
Yeah, this particular drug, exactly. So you got to get a little creative in how you get a hold of it, but well worth it to hop across the border for that. So was there another drug?
Yes. So after this, Gail called us up and said,
now we're up to May 15th of this last year.
Well, okay, so Alex told me that gefitinib will fail, and so did my oncologist at the Mayo Clinic, Dr. Carlin. She said, when gefitinib fails, you should go on fulvestrant. And Alex had told me the same thing. And this is something I want to bring up, Alex, that is an important point, because I did not understand the difference between fulvestrant and anastrozole, exemestane, letrozole, which I had been on those hormone suppressors. I thought, why would I get an injection for a hormone suppressant when I already had these tablets and injections that didn't work? And then finally this summer, you explained to me that it's actually suppressing the estrogen that the tumor is producing, not the estrogen that my body's producing. Once I had that information, then that gave me the information I needed to fight for the prescription that I needed. But before that, I didn't really believe in it because I didn't understand it.
Yeah.
So that's something going forward that needs to be explained to patients.
Yes.
Right.
And you know, that was probably partly due to my poor lack of communication.
Well, no, I mean, you don't realize, like, for a layperson, you know, you don't know what I don't understand.
Oh,
Yeah.
but it's back to that thing, really, what you've just said is reinforcing what Alex said a little earlier about the mechanism. It's not just important for your doctor or for Alex, first and foremost, to understand the mechanism to make the recommendations from the data about treatments, but for you as a patient, for your doctor, hopefully, to understand this, why this matters, why this works. I can totally understand why you were thinking, you know, aren't they kind of one size fits all over here?
Yeah, and that's why I needed to be educated, because as it turned out, I really had to fight to get the fulvestrant.
Yeah.
And I needed to understand that, just as every appointment he said, I think you should go on chemo. And every appointment I'd say, no, I have to give up Metformin, or, you know, and then finally he said, well, what do you have against chemo? And I said, well, I have to believe in it, and I can't believe in it when I have such a low response rate. And I'm already on gefitinib. At that point, was still working 85%. And I said, I put it to him, I said, would you give up 85% treatment result for a chance at 15%? And he said, honestly, no, I wouldn't. So, you know, it's his job, I guess, to push the chemo.
Yes. So the next stage, which is really quite interesting, is we noticed, Gail, that you had your previous one of the analysis in your pathology from years ago. It said that there was expression of the estrogen receptor alpha, and this is common in estrogen positive breast cancers. It's actually not so common in ovarian cancers. We usually see high estrogen receptor beta expression, which is a completely different thing. And so estrogen receptor alpha. And so we looked at that and we thought, okay, well, this is interesting. And so around that time, I said, let's do an RNA expression of your tumor. We hadn't done that yet. And let's look at this panel. So we took a sample of Gail's tumor and we ran it under a 21,000 gene RNA expression panel. Basically what we did is we took the tumor sample. We had our specialty pathologist in the States, from in vivo, in vitro, who are one of the best pathologists in the world. They do pathology for, you know, many clinical trials and so on. We had our expert use laser dissection pathology to isolate the tumor cells from the tumor block that we had for Gail. And he gave us a purified vial of tumor cells. And then we had the RNA extracted from that, the tumor RNA specifically, and then we sequenced that and looked at the expression, and we compared it to a variety of different tissues, specifically ovarian tissue and fallopian tube tissues. And we found on that a bunch of overexpressed genes, but one of those genes that was highly overexpressed was the estrogen receptor alpha. And we thought, wow, this is really contributing to her disease. And it was overexpressed by almost 15-fold, almost 15 times what normal ovarian tissue would have. And this is a huge driver. So we knew that this was a significant driver. And so I looked in Gail's records and I noticed she had only been on an aromatase inhibitor. And so aromatase inhibitors inhibit the production of estrogen. And they do so through a pathway called the aromatase pathway. And typically the aromatase pathway is a pathway where various cells in the body will produce estrogen from testosterone or other androgens. So basically just alter it, tweak it, and then turn it into estrogen. Males have the same pathway, but they also produce estrogen and convert it into testosterone. So it's kind of the backwards pathway. But it's a common pathway in most cells. And we knew that these cells in the body were actually sensitive to estrogen receptor alpha inhibitors. However, Gail had only been on the androgen receptor inhibitors, which, as we know, prevents estrogen. It doesn't target the receptor. And so for every mechanism, you have what's called the ligand and you have the receptor. The ligand plugs into the receptor on the tumor cell and turns it on, creates a conformational change, and that causes the cells to grow and metastasize. So blocking the estrogen is one thing, but you still have this estrogen receptor, and that estrogen receptor can sometimes signal by itself. It can also bind other things potentially. In cancers, anything can happen. All we knew was that there was an increase in that estrogen receptor, not the estrogen itself, the estrogen receptor. And so we knew that the aromatase inhibitors would have been useless. And so we suggested fulvestrant. Now, there's two drugs that target, well, there's actually a lot of drugs that target the estrogen receptor now, but the ones that are available are tamoxifen. And tamoxifen targets the estrogen receptor alpha and beta. And when you use a drug that targets the receptor for the alpha and the beta is like the brakes on a cancer cell, and the alpha is like the gas pedal. So tamoxifen has kind of opposing roles. It also inhibits processes that will inhibit the cancer itself. So it's not the best drug for that. And as a consequence, tamoxifen can cause reproductive cancers. That's because it inhibits the estrogen receptor beta as well. And a lot of reproductive cancers like ovarians and fallopian are driven by the estrogen receptor beta gene, not the alpha. Breast cancers are driven by the alpha. And so when people take tamoxifen for breast cancer, it can sometimes cause ovarian cancers. So we knew tamoxifen wouldn't be the right drug. So fulvestrant is a targeted estrogen alpha receptor. And that's why we thought that drug should really help in combination with gefitinib. So we did some studies. We found that you can give estrogen, we can give fulvestrant with gefitinib. We found that they're not contraindicated. And we made the suggestion that Gail give it a try for 3 to 6 months, because we really felt that it would make a difference. And so Gail, how has that worked out for you?
We felt it would make a difference because the estrogen was so overexpressed.
Estrogen receptor, not the estrogen. Estrogen receptor alpha was overexpressed.
Was so overexpressed
in her tumors.
And you found that out through this RNA
expression testing, yes. Okay. Now, we did find a bunch of other potential treatment options for Gail for ADCs, but that's a completely different conversation.
Okay, that's for down the road.
Yeah.
Down the road, yes.
All right, so back to what Alex was saying, how has it been for you? What's your experience of adding this fulvestrant? Or tell us a little bit about getting it. How did it?
Yeah.
Okay. Well, also I'm on metformin.
Yes, Metformin too. Yes.
Yeah, and that's for the PIK3CA, isn't it?
Yeah, Metformin actually is it's an anti-diabetic drug, but it also it reduces insulin, but it also works on a bunch of other mechanisms. One of those mechanisms is, as we call the PIK3CA, AKT, mTOR pathway. And so metformin works on mTOR, which is a little ways down the pathway. And so we knew metformin would also modulate this cancer because Gail does have this PIK3CA signaling.
Yeah.
Now we tested through ctDNA, we tested Gail's blood using a digital PCR to look at the level of her PIK3CA mutation. And it had been very, very low. So we knew that there's no point targeting that mutation with alpelisib because it's not actually a driving mutation right now. It may be in some point in time, and then alpelisib will be useful then. But right now, it's not a driving feature. Whereas the estrogen receptor and the BRAF, was actually altered in your tumor by 10.6-fold overexpression. And so, of course, this is why gefitinib is working so well. So we knew that having these two drugs together would probably be very effective. So sorry, Gail, I didn't mean to.
No, that's okay. Michelle was asking how it's working for me. It's working very well. After my September CT scan, I had more bad news. One of my tumors was putting pressure on my right kidney, and there was some moderate swelling. And doctor advised that I would need, they would have to insert a tube in my back. And he said within 3 to 6 months, like he wasn't sure. Anyhow, since being on fulvestrant, my bone pain is gone in my hip and in my lower back. My kidney is no longer an issue, my right kidney. And some of the tumors have reduced in size. And I just feel better because I have quite a burden, right? So it's kind of hard to describe, but kind of a full feeling, in my abdomen. I'm carrying these tumors.
Yes.
And so I do feel better in that regard as well.
And
So
how about the
overall,
blockage?
it's an improvement.
How about the blockage that you had in your colon?
Well, so that I'm still concerned about because I don't know whether that tumor has reduced in
Now,
size, and
didn't you?
I'd have to ask my doctor or you or someone.
Yeah, I saw that it had resolved.
Well, the radiologist that read my last two CT reports
Yeah.
was the same radiologist, which is great because
Yeah.
they all are all over the map. This guy
Yeah.
tells you this, and this guy tells you something, looks at a different area, and you can never match it up. But this I could, because 2 in a row he did the same. So when I'd had my blockage in May, it was a tumor pressing on my intestine,
Yeah.
and so I had to go on a low fiber diet.
Yes.
And I'm still concerned about that because I don't want to end up in the ER. It's happened twice.
Yes.
And I know you recommended the Mediterranean diet,
Yeah.
and
Yeah.
that's high fiber.
Yes.
And I thought, well, maybe I could blend some vegetables, some spinach and tomatoes or something. I don't know.
Yes.
But I'm still concerned. I guess I need reassurance about not having another blockage because that's a serious event.
Yes, definitely. Yes.
Yeah.
And so when did you start, sorry, just for the timeline, when did you start your tamoxifen, or sorry, your fulvestrant?
My first injection was September 19th.
September 19th. And then you had so the last scan that I have is on the 20th.
November 20th.
Yeah.
Yeah.
And so that one showed almost it says almost complete resolution of your ascites.
Oh, that was fluid. That's fluid.
Yeah,
I
those
have
are the
to
tumors.
look up a lot of these words when I read the report.
Yeah,
That's
yeah.
the fluid. Yes, so that, I guess that helps with the fullness I was feeling.
Yeah.
Right?
And
The kind of, the
yeah,
pressure.
for the fullness. Yeah. So
Yeah.
ascites are one of the most hardest things to deal with cancer. They almost don't respond to anything. They're little fluid-filled tumors in the abdomen, and they could be a real problem. And you've had, it says, almost complete resolution of your ascites with only very small pockets of fluid. And most of your lymph nodes are stable. They've gone down in size. Yeah, pretty well. I'm looking at everything. And they did not notice anything about your blockage.
No, because I'm on the low fiber diet, so I'm very careful.
Mm-hmm.
And I'm just concerned about, if I start eating a lot of fiber, am I going to end up in the ER again? And
Yes,
I don't know how can I get reassurance about that?
Well, this is the thing, and the scan that you did was only 1 month on fulvestrant.
Yeah.
So
2 months.
Was it 2 months? Okay.
Yeah.
Late September to November 30th, month and a half, isn't it?
Yeah. No, I had injections on in September, October, and I actually had my November injection, but a few days later I had the scan.
Okay, got it. Yeah. Yeah. So let me just look.
September 19th, you started the fulvestrant, and then the follow-up scan was the 20th of November. So yeah, 2 months.
2 months.
Mm-hmm. So I guess the point that you're getting at there, Alex, is that obviously that's a significant response.
Yeah, that's great.
And given that the CT scan is saying that that blockage in the colon isn't really discernible or not worthy of mention.
Yes.
I can understand why you want to wait and see for sure on the next scan before you.
It's really scary. Like, it's a nightmare. You end up in the ER. It's a nightmare to deal with.
Of course.
Yeah. So if you can avoid that for yourself, that makes
So
sense.
so what it says under your bowel, it says prior total colectomy, the remaining bowel loops are within normal limits, no obstruction or any other acute pathology in the bowel.
Okay, but it was a tumor below my intestine.
Okay.
Like, let's say right below 3 inches or so below my belly button, like way down there.
Okay.
The tumor was pressing. So I don't know, is that tumor reduced in size? That's what I don't know.
Yeah.
Yeah.
Well, it says there's nothing in the bowel. And it says pretty well all other, it says everything else compared to, and this is compared to September 2023, not, so that's just very recent. That's like,
2 months.
Yeah, 2 months.
Yeah.
So, I think having this much of a response and having your ascites disappear and
know.
your bone lesions becoming stable and your L2 and your
I know.
S1.
I was just
And
thrilled and surprised about the bone
yeah,
lesions.
yes. I mean, we would expect a partial response, but it seems like just about everything is responding now.
Yeah, I'm thrilled. Like
Yeah.
I couldn't believe it. I had to read the report twice
Me too.
because everything said no.
Me
Usually
too.
it's like, yeah, this is bad, this is bad, this is really bad. But no, it was all good.
And so what has your doctor said since that last scan?
He's thrilled. He said he was absolutely thrilled by it.
Right.
And now he's spaced my appointments now. My next appointment is end of January. I have a CT scan and a follow-up end of January. So 2 months.
Great. Wonderful.
Yeah. So I think he has some confidence there.
Yeah. So let's ride this out as long as we can. And then once it stops working, we'll go on to plan B.
Yeah. You had said there are other forms of fulvestrant that we can
there's
try.
newer forms. Yeah. They're
Yeah.
designed for mutations in the estrogen receptor specifically. There's been about 4 of them that have been developed. A couple are approved now. And they seem to work really well when fulvestrant stops working. So it's lots to look at there. We have a massive amount of data for your cancer. So
Well,
there's lots of different
so
approaches
pleased.
we can look forward to, and try this and try that. And really with a cancer that has no other treatment options, having treatment options is really key here.
Well, I get a kick out of how oncologists like the language that they use. He said, yeah, your cancer's underserviced. It's so subtle and understated,
Yeah. We call it an orphan cancer.
Yeah. But anyhow, thank you so much for everything you've done to help me.
Well, Gail, so much of it has been you advocating for yourself, you talking to your doctor, you taking the time to understand the information. And as you understand, this is not simple, stuff. This is very, very complicated molecular analysis that you were able to translate to your doctor in some manner to convince them to prescribe these drugs that are completely not even matching the mutations in some cases.
Well, I treated, I guess, like I said to Michelle when we first started chatting this afternoon, as a job. And I want to approach my consultation with my doctor fully informed to the best of my ability and confident. Like I don't want to go in there stuttering over medical terminology, not knowing what I'm talking about. What am I asking for? Do I believe in it? It's very important for me to understand it and believe in it. Then I can fight for it.
Yes, exactly.
Yeah, that's a key for me.
Right. And that's where the genetics really come in, because that's where you got a chance to see exactly what's going on in your body and understand the mechanisms, understand why this drug is going to be so beneficial for you in a way that your doctor didn't understand.
Well, of course, and at one point he was, when he was pushing the chemo, he said to me, I recommend that you start chemo as soon as possible, like next week if possible, etc. And he went on about it for a bit. And I said, okay, thank you very much. I'll take that under consideration. And he burst out laughing because of my reaction, right? Like I wasn't agreeing to it because I had no intention of doing it, but I was being polite. Thank you. I'll take it under consideration because I knew otherwise, right? I had a different plan and I just had to work at convincing him.
Yeah.
So anyhow, we get along well. He's a very nice man and he's been very supportive and helpful. He's given me the prescriptions that I've requested. So like, don't get me wrong. I like him and
me too. I like him too.
Yeah. So, but we've had some funny exchanges along the way because we disagree.
Well, I think you've taught him a lot too.
I hope he's learned a lot, but I think he has, because at first it was always, but that's a different disease. And I'd say, but it's the same mutation.
Exactly.
And, because I would go in there and I would have read a case study or a clinical trial or something. And it was on breast cancer, let's say. And he'd say, but that's a different disease. And I said, yeah, but it's estrogen positive. It's, it applies to me, it's different. And okay, I mean.
And
You
that is,
believe what you believe.
but that is
Yeah.
the consequence of our standard cancer care system still seeing cancer as the location of the primary
Yeah.
tumor. And, you know, designing a plan around that as opposed to these genetic or molecular features, which, you know, as you've educated your doctor and as Alex has helped you learn, really are the secret sauce. That's what's driving the bus, and that's what needs to be addressed. And so if you follow the cookie crumb trail from your genetic testing to the most current peer-reviewed medical science, you can often find some pretty creative solutions that will knock it out of the park, as it is for you.
Yeah, and I'm hoping that the information that I've provided to my oncologist, he'll discuss with other oncologists, and maybe that seed will grow and spread.
Yes.
And others will have an easier time with their oncologists as far as requesting and convincing, you know, for precision oncology treatment.
Yes, yes.
Yeah, the key right now, as you're well aware, is that the diagnostics required to identify these mechanisms and to have the confidence and the evidence that you had to successfully advocate for those treatments, it's just not part of standard of care.
No, it isn't. And even a lot of my friends and family say, like, but we have public health care. Why are you paying privately? And I said, well, if I was in legal difficulty, I'd hire a lawyer
Yes.
as an expert to help me. And I'm in medical difficulty, so I've hired a cancer scientist, right? In simple terms,
Yeah,
I need your
exactly.
expertise. It's
Yeah.
this, you know, it's the same, it's an analogy that I use, everybody understands. They're like, well,
Yeah.
that's a good point,
An
right?
well, and even, you know, think about how Alex and his team went through your entire medical history. Like Alex mentioned, looking at a very old pathology report, you know, and that turned a light bulb on. And in our standard of care now, doctors just don't have the time to review 10 years of history. They're looking at the most recent data, and then they're operating from their standard of care menu based on the location of your tumor and not the mechanistic features. And that's really why there's this big chasm between what's possible versus what is offered in standard of care. So just having
whenever I discuss anything new or have a question about what I've read with my oncologist, I always preamble and say, I understand you're very busy and I know you can't read everything and there's so much out there. Like, I'm not pointing the finger, and I don't want them to think that I am.
No.
And I understand that they can't keep up on everything.
No, and right now in Canada, and many countries around the world, frankly, there's such a shortage of oncologists. I mean, you had a surgeon navigating your case for quite some time.
Well, that's because the treatment was surgery, right?
Right.
So for 10 years, I had a surgeon.
Right.
And then I got to the point where no more surgeries were offered. So she referred me to a medical oncologist. But that was interesting because that's when I learned that when I presented the same questions to the two doctors, and they both had different responses, and I realized that he had read this study and she hadn't read this study, and so they both had different opinions and answers for me. And that's when a light bulb went off, and I thought, oh, like they're not all on the same page, not even the oncologist.
No.
And so then I understood more that it solely depends on what you've read and what your experience is. And so then it's more on me to be my own advocate to make sure that everything is covered, and I have to track everything and make sure my questions are answered and follow up and so on, because they don't have time and they probably haven't read this anyway.
Yeah, and where I was going about the oncologist is just that there's such a shortage, and so most oncologists have about 3+ times the caseload that they're supposed to have. So as you're well aware, the amount of time we often get with our doctors is greatly diminished. And then of course there's, you know, just as you discovered in those very early days, just getting your GP to take you seriously and start to get the testing done to even identify that you had cancer. It took a while, and you had to get yourself a new doctor who was just
it was a person covering off for my GP. My GP wasn't the problem. She was on mat leave. I think she had about 3 kids during this time. So she was on mat leave quite often. And so I would have to make an appointment with a doctor covering off who's like, I don't know, didn't know or care. I don't even know what the problem was, but yeah, that was an issue.
Yeah. So we see that there are a lot of excellent people working in the healthcare system, people who are well educated and who do have excellent intentions towards your well-being, but the tools they have access to and the number of cases that they are expected to see
I know.
prevent them from even looking at your history, let alone getting creative in their solution.
Oh, absolutely. And so my appointments with my oncologist, monthly appointments, are 15 minutes. And I did mention that when I requested the fulvestrant and metformin, I was in there for an hour, which then pushes everybody else back. I understand that, but I needed to have that prescription and I wasn't leaving without it.
Mhm.
And I asked him during that appointment, I said, "Am I your most difficult patient?" And he said, "No, you're my most time-consuming patient." Because I always have so many questions, right?
As you
Yes.
15 minutes isn't enough.
That's right.
But on that same token, you know, you're putting him on the map within his facility because people are going to say, you treated a granulosa, you know, tumor cell with a EGFR inhibitor and a estrogen receptor inhibitor. That's amazing.
Yeah.
So he's going to get credit for that.
Yeah. Yeah. Well,
which is great.
I hope so.
Yeah, I do
because
too.
he is a member of our team, right?
Yes. And he's the
Yeah,
one that took the courage to prescribe it. So
exactly.
totally deserves credit. Yes.
I agree. I
Yeah.
agree. I see it as a team. So I tell my friends and
Exactly.
family that
Yeah.
you know, there's CTOAM, there's my oncologist, and then also I still have Zoom meetings with the medical oncologist at the Mayo. I just stay in
Right.
contact with her because I'm like, it's the Mayo Clinic. You know, they might have information that we don't have here in Edmonton.
Yes.
So I discuss things with her too.
And so what has she said about everything then so far?
Well, she agreed with you about the fulvestrant, like right off. She said, without me even telling her that you were recommending fulvestrant, she said, when the gefitinib fails, you should go on fulvestrant. Right? So that reinforced, I thought, I better learn more about this fulvestrant because both Alex and Dr. Carlin are saying I need to do that. So yeah, that encouraged me.
And what did she say when you first told her that you were doing gefitinib for a BRAF mutation?
She said she'd never heard of that. And she was very interested to follow me.
Yes. Yeah.
Yes. Yeah. So she was open to it.
Yeah.
She says, yeah, I've never heard of this, but yeah, she's very interested.
So your case,
you know, once again, really goes into understanding the mechanism. And really, I mean, a lot of geneticists I know are not going to know the difference between the mechanism of a BRAF V600E class 1 mutation and a BRAF, you know, what is it? A K499E mutation, which is a class 2 mutation and has a completely different way of getting turned on. You know, they're not going to understand that. And we didn't until we'd done the research on these two mutations.
Yeah, it's fascinating. See, I always understand everything. You explain it so well to me, Alex. I want to compliment you on that. I do. But then I go away and I can't explain it to anyone else because I can't remember all the terminology.
Yes. Yes. Well, it's important you understand it. That's the most
exactly.
thing. Yes.
That's right.
Yeah.
That's worked.
Thank you, Alex. Was there anything else you wanted to add?
No, I think that's it. Yeah.
Okay, well, you can head on out. And
okay, Gail, I'm looking forward to your next CT scan.
Me too.
Yeah, and have a wonderful Christmas. I'm so glad everything's working out for you.
Thank you so much.
Keep up the good work. Take care.
Thank you. And you too. Merry Christmas.
Yes. Okay. Bye.
Thanks,
Bye
Alex.
now. I guess I just want to say that to encourage patients to be their own advocate, because when you have a rare cancer, as I said, it's underserviced. You're the only person you can count on.
Yeah.
Right.
Yeah.
And so I would encourage them to show initiative and take responsibility for their own treatment. Yeah.
It's like you were saying earlier that it wasn't until you had those two opinions that were differing that you realized, oh, not everybody has the same level of understanding or same perspective on this. There are other opinions, there are other things and ways to go, and that hadn't, for good reason. You'd never been through this before. It hadn't occurred to you, but once it did, all the light bulbs went on, and
Yes. Yeah. That's right.
Yeah.
That's
so
right.
Yourself is key, absolutely. And I also really appreciated what you said too. It's so important, which is it once you were able to understand the mechanism, what is driving this cancer, what is going on, and that was the, you know, the combination of the DNA and the RNA testing, it just made so much sense to you that even though your doctor kind of stonewalled you for a good hour there and was not at all thrilled with the request, you understood. It wasn't just Alex telling you get this drug. He was saying, here's what will work and why. So your understanding made it so you were not leaving that office without that prescription, because
right. And I had to, as I've expressed, I had to feel confident in what I was asking for. And in order to be confident, you have to understand it.
That's right. Yeah, that's right. And so somebody can't just tell you.
No.
You need to see, here's the mechanism, here's why it's not just someone's opinion, you know, this is how this works. And then you could do the math for yourself, and it was a no-brainer. Okay, well, yeah, obviously we're going to do this drug, and then okay, obviously now we're going to add this one, and look at where you are.
Yeah, I've got to get it. And my heart sunk when after an hour I still don't have the prescription. So
that must
but
have
he came through. He came through.
Good. Yeah, exactly. Yeah. And I just want to reiterate for you, we have mounds of empathy for what doctors are dealing with. Again, the size of their caseload and the tools that they have to work with. So what really is important is exactly what happened here, is that when the evidence is presented to your doctor, that they're willing to expand their menu, that they're willing to explore something they otherwise wouldn't have even known to do or thought to do. Even the Mayo doctor, I hadn't thought about that for this.
Yes.
Yeah. But as you said, in both cases, with the right advocacy and the data, most doctors are very willing to get on board, but they can't do this research for you. They don't have the time, and they don't.
Of course.
Yeah.
Of course, because when I first asked my surgical oncologist at my follow-up appointment about, you know, that was my dipping my toe in the water, about drugs that might be available and treatments. And she's like, and I don't blame her for saying this. She goes, that's a lot of work and I'm so busy. And I understand that, but I needed to ask someone, like I needed to start somewhere.
Right. Yeah.
So, and I felt bad asking, but I thought, well, you know, this is my life I'm asking about. So I had to ask.
You did, and no need to feel bad by any means, or anybody else who watches this later. But that was absolutely, what an authentic response. You know, it's not an easy thing for a doctor to say, is there may very well be something, but I literally can't look for it for you.
Well, when you think of being a surgeon, and yeah, she is so busy, right?
That's
super busy. I understand that, but I had to start somewhere.
Yeah, and you did. Yeah,
I did. Yeah.
So, so what do you wish, if anything, that you had known earlier that you know now?
Well, at the beginning, once I found out that I had recurring granulosa cell tumor, which was the double rare, I wish that I was aware of, for example, CTOAM and how I could get help with the DNA testing and send me on the right path for treatment. I could have avoided numerous surgeries. So after surgery number 2, I could have saved a lot of grief and suffering.
Yeah,
well, when I'm at the Cross Cancer Institute, they always have these racks with information brochures for patients. Maybe you can get one of your brochures in there.
Yeah,
you know, honestly,
that's a fabulous suggestion.
Yeah, because we could have saved a lot of medical expense, time with doctors, etc. if I had been able to cut it off at the pass there.
That's right.
Get the proper target treatment.
It's true.
Instead of just waiting for the next surgery, right?
That's
waiting for the disease to develop.
Yeah.
So that's a recommendation. Be prepared to private pay for drugs that are developed for other cancers, because there isn't anything for you if you have granulosa cell tumor. So don't be shocked.
Right.
Yeah, private pay is a fact.
Right. So especially as you say, if they're considered to be off-label therapy.
Yeah, well, everything's off label for me.
Right.
Like even the fulvestrant, I pay $1,250 a month for the injections.
Is it every month you're getting one?
Yes.
Yeah. Okay.
Yeah.
Yeah.
But I've asked my oncologist if he would ask the cancer board to consider to fund my injections, and I haven't heard back yet. He's presented that. So
Fingers crossed. You know,
yeah.
90% of the time it will be a yes. Because now you've done all the heavy lifting of getting the testing and prove, and now you've got 3 months of proof and a couple of CT scans to prove this is working. It's
Yes.
a lot harder for them to resist, and we've seen that be the case fairly consistently. So good for you for asking. Fingers
Yeah.
crossed on that.
Yeah.
Oh,
See, Alex has trained me well.
yes, really.
He didn't have to prompt me on that one.
Yeah, that's awesome. Yeah.
Okay. And another thing I'd like to say is, because I've received a lot of bad news over the years, take the time to feel sad for a day or two, right? When you get bad news, don't just brush it aside. Take the time and then move forward. Pick yourself up, dust yourself off, think positive thoughts, hope for the best, look to the future, right? Move forward. Don't let yourself spiral down, because that's not going to get you anywhere, right? You're going to fail.
And at the same I appreciate so much what you're saying, which is, I mean, and it can be the hardest thing to do, is to allow yourself to feel that grief or the sadness or the fear upon hearing the bad news, because we can assume, oh, that's going to make me spiral. It's going to take me down. And of course, you know, many of us have off the side of our desk, even perhaps been, informed about the power of positive thinking and things like that. And so we can assume that to allow those feelings of fear and grief and sadness and frustration is a negative thing. But it's such an important part of the healing process, and of you being able to kind of let that energy go and then focus, okay, well, I'm not dead yet. What am I going to do? Right? Really?
Like, this CT report really sucks.
Yeah.
And, you know, just let it suck for a day or two and say, I don't like it, but now what can I do?
Yes.
Right?
Exactly.
Okay. So, and I've told Alex this, and I'll share it with you. I've said, Alex pumps me up. Like, he's always so enthusiastic, and he's got hope, and we'll try this, and there's these options, and there's this coming down the pipes. There's new research on this. There's, conjugate drugs in development, and they're getting approved all the time, and just so enthusiastic. I'm like, cool, like, wow, I'm just pumped, right? And then I go to see my oncologist. He always leads with the bad news.
Right.
Okay, so I had CT that the gefitinib was still holding my cancer growth at 85%, but he leads with the 15% that's progressed. And that was the kidney, I'm like, oh, and it went on and on. It was so bad. And, you probably have to have a stent and it'll be permanent and all this. I'm like, but what about the 85% that's working?
Yeah.
So finally I said, wow, every time I talk to you, you've got bad news. He goes, yeah, I know, I'm sorry.
Right. Yeah. Well,
yeah.
I guess their training is focused on what's wrong and what we might do about that. Right. But it would be nice. There was just at least a pause to say, whoa, 85%. That's
exactly. So I have to bring that up. What about 85%? But so it's a good balance with Alex, because he always, like I say, and that really helps lift my spirit and continue with hope and moving forward. Yeah. Right? Because if I always had bad news, maybe I wouldn't be as positive.
You wouldn't maybe have that open mind that was looking for solutions. Absolutely. And yes, it certainly would affect just your overall feelings as you about your life, and every minute really counts.
And so I have Alex to thank for that, and I have thanked him. I did tell him that.
Wonderful.
So that's why I say he's part of the team. He's part of my team. Absolutely. And I couldn't do it without him. So I do appreciate him.
Oh, wonderful.
Sure, he sees. And also never stop searching for treatment options. So if I hear of a new treatment for any cancer, I look into it. Would that be applicable to me? As I mentioned, the Keytruda, right? Oh, that's worked for a couple of people that I know who are ill. but no, it's not applicable to me, but it doesn't hurt to look into it or ask your doctor or ask Alex.
That's right. And once you've got all the testing done that you've got now, yeah, you've literally got information about every gene in your body. So when you learn about a new drug, you can look on PubMed and have a look at what is the mechanism of this drug? What does it target? How does it work? And you yourself can look at your genetic test results and say, is this relevant or not? And of course, you can go out and ask Alex too, but for you to be able to have the power to be able to assess, is this going to benefit me or not? That's remarkable.
Yeah. So I always keep that in mind. And I also maintain a list of questions before each appointment with my oncologist. So maybe things I've discussed with Alex, or questions I have about treatment, or, anything like that. I keep a running list.
Great.
And take it with me.
On your phone, or what do you find works really well to kind of keep
I'm old fashioned. I'm a paper person. Before I retired, which was in 2019, the younger people in the office used to say, Gail, how many trees did you kill today? Because I would make notes, print them. But guess what? I'm the person who never forgot anything because I had a sheet of paper.
Yeah.
I didn't have the blank desk. And, because I don't get rid of the paper until the task is completed.
Yes.
Yeah. So that's just how I work.
Stack of paper, I'm sure right now associated.
Oh, absolutely. I've got tons.
Yeah. Okay. So keep a running list of questions as things come up, so that you're ready to go with these important things when you get your 15 minutes with your doctor.
Yeah, exactly. And I already brought this up, like, feel confident when requesting prescriptions for target drugs. And, that's very important, the confidence, not hemming and hawing. Well, I kind of would like to get this. I don't know. Right. Like, you have to be confident.
That's it.
Yeah.
It's got to be a statement rather than a question. Right.
Exactly.
I know this drug is going to benefit me because I understand how it works and I understand the mechanisms of my genetics and my cancer. So I'd like a prescription, please, as opposed to, what do you think? Could I possibly?
Yeah. And part two of that is, like, don't back down if you know you need it. Right. And it's hard to, you have to be respectful and kind, of course, when dealing with your doctor, but how am I going to twist his arm to get it? Exactly. You have to think on your feet. And
well, you did the don't take no for an answer approach. Again, your confidence that this was the right drug and would benefit you is a huge part of that. And just again, like, this is, nobody is going to fight for you as hard as you fight for yourself.
Exactly. Yes, that was my number one point. Be your own advocate, because no one else is going to be.
That's right. Yeah. Even with us on the team, at the end of the day, it's you. We'll do whatever help you need, and we'll step in and advocate as and when needed. But fundamentally, this is your life, and as you're telling us, it's something you really have to fight for right now, but so worth it. And the result that you're having right now, it wasn't that long ago you were told you had about 6 months, and now here we're having such an incredible response to these treatments, and these CT scans are showing this resolution.
I know. Kudos, Alex.
Yeah, I know. It really is quite remarkable what he and his team do. And again, just coming back to even their thoroughness of looking at all the medical records and finding that one little bit of data in that report, that really kind of turned on the light bulbs and got you to where you are now.
It turned on the light bulbs, but it made the doctors go, what?
That's right.
No, that doesn't make sense.
No, exactly. And yet with the genetic data, we were able to show how it does for you. Yeah. And then again, with you just not giving up on yourself and advocating. One of the things that you may or may not have done, but it's a helpful thing to go along with the, understand the mechanism, be confident, know that you need to be your best advocate, and don't leave without that prescription. Yeah. A lot of times doctors will say, no, that's not something that we normally do for you, or that's not warranted in this case. And in that case, just take a nice deep breath and you just say, please help me to understand what is your resistance to this particular request. because we kind of want to put doctors in a position of having to say, I've just never heard of it before.
Yeah.
You know, I mean, and I mean, frankly, if they do have a legitimate reason that isn't just it's new to me, or I don't understand genetics well enough to know if this is really right for you or not, if they have a good reason, they should be willing and able to articulate it for you.
Yeah.
Oh, well, you know, with this mechanism and your type of cancer, here's what can go sideways, or here's a side effect I'm just concerned about for you because of
Oh, yeah. And he does, like when I talked about gefitinib for the BRAF mutation, he goes, well, that doesn't make sense. BRAF, that's further down the pathway and down the line. I don't know. He did have an explanation.
Right.
And
right. But that was again based on the standard BRAF mutation, which you have, right? So
yeah.
ask those questions about what's your reason for saying that, doctor, or help me. I respect your experience, because of course we do, and they are on
the yes, definitely.
You've got to understand it's their medical license on the line for whatever they prescribe.
Absolutely. That's why I say, you know, be respectful and kind, but at the same time, you've got to try and get what you need.
Exactly.
And I understand when he said he felt uncomfortable, and I thought, well, now what do I do?
Yeah.
Right.
So what you did was absolutely perfect, because when a doctor says I feel uncomfortable, they're not saying no. They're saying this is new to me, and I've never monitored somebody with your type of disease with this drug before, is really what they're saying.
Yeah. Well, and I said I take full responsibility. You know, I won't hold anything against you. And it's my body. You know what I mean? Like I won't come back and say, hey, it's your fault. This went wrong.
Yeah. And that's so you were able to show the mechanism so they could see the scientific basis for what you were asking for, and you were prepared to accept full responsibility for how it went. And that is the secret sauce. Yeah. 100%.
Yeah. I guess one other thing was Alex had said that, you know, once you have positive data, that there's a possibility of getting cheap drugs or free drugs. Like what is the mechanism to approach drug companies, and when does that happen, and how does that happen, as far as like I'm still paying for gefitinib and I'm trying to get funding for fulvestrant, but is there a point where there's a trigger that says, oh, okay, now we can ask the drug company?
Yes, exactly. And so the vast majority of the time, patients don't have to pay out of pocket for drugs, but because you have this orphan cancer, and because essentially everything other than chemo is off label for you right now, you did have to pay out of pocket. Again, back to the discussion of international pharmacies and reduced prices, at least. But that's part of the issue that you were dealing with, is that because these things are off label, public health care won't kick in. But what you've done now, and what we've seen time and time again, is that once you can prove with routine diagnostics like the CT scan that the drugs that you are receiving are benefiting you significantly, usually the public health care system will pitch in and start paying for them, at least for a time, if not, you know, until complete response and beyond. So what you've already started is what we would advise, which is
okay. So I'll still wait to hear. Actually, I'm going to call this afternoon because my next injection is next Wednesday and I haven't heard.
Yeah. Okay. So definitely check. Again, as with everything, things take 10 times longer than they should right now in the public healthcare system, because the caseload is just so great and the personnel is so limited. But by all, what you've just said is exactly what I would advise, is stay on it.
You're right.
A lot of times in our healthcare system, I'm not saying it's right, but a lot of times in our healthcare system, the squeaky wheel absolutely gets the grease, simply because things fall through the cracks. People forget, messages don't get relayed, or
absolutely
can be sitting in your file for a month before the doctor even sees that it's there, because they're not meeting with you for another month.
Well, I know that unless I follow up, like I don't, you know how it used to be a standard that you would acknowledge someone who sent you a letter or a phone call or a request? No. They don't acknowledge you even.
No.
So you have to follow up.
That's right. Exactly. That's exactly it. So, and this is where we come back to, don't be afraid to be a squeaky wheel, and Gail's specific advice here about be your best advocate. You are your best
Yes.
advocate. You have to have your back. You can't be afraid of ticking people off. No, keep a respectful tone, keep your body language as neutral,
Always.
right?
Always say please and thank you.
That's right. But be firm and don't
Yeah.
expect things are happening. Don't
Yeah.
expect them to be.
No.
You need to call and make sure that referral went through. You need to call and make sure that the tumor board has received your file. The person at the front desk can check your file and tell you, did that message go through? Has anything come back yet? So you don't have to speak to your doctor to get that data. And of course, we can gather all your records for you anytime and all the time, and just keep updating them so that you always know, yeah, what did the doctor's note say, or has that actually happened or not? But your plan, yes, call anytime, see at least, has the referral gone through to the tumor board? Has there been a response back? So you're not waiting and wondering if it's even happening.
Well, because I have to then order it from Shoppers Drug Mart, right? And they need a few days lead, right? So there's logistics involved too. But yeah, I will phone because I would like to know whether it's been approved.
Yeah. So once you get that information, let me know, and then we can see what we can do about, back to international pharmacy or other ways perhaps to get you a deal. But also at this point, is there something we can do to encourage?
Well, I checked, and Affordable Meds in Florida does not provide fulvestrant. And I believe the reason for that is because it has to be refrigerated.
Oh, could be.
Yeah. So
There-
when I pick it up at Shoppers Drug Mart, it's refrigerated, and I have to bring it to my fridge at home. It's not on their list of meds when you go on Affordable Meds. I checked.
That's just one of many possible pharmacies, so we can certainly for others. But yeah, sometimes that is the case, that they don't want to sell a drug because they can't guarantee it'll get to you and still be cold.
Viable, yeah.
Mhm.
Yeah, because if it's not refrigerated, then it's useless.
Yeah, that's it. That's can be some of the difficulty here with some of these deliveries. So yeah, let's check into that. Let me know what happens with your follow-up about the tumor board and their approval. And then we can start looking into other ways that we can get you some access at a reduced cost for that drug too.
Okay, that'd be great.
Start adding up. I appreciate it.
Yeah, and when Alex, getting back to cost, when he talked about Alpelisib was the first recommendation, which is no longer applicable. Because things have changed. That was 8,000 to 10,000 a month for Alpelisib. And the other negative was with my low fiber diet, Alpelisib, you had to go on a diabetic diet, which was high fiber.
Oh.
So yeah, that wouldn't have worked for me.
Right. No.
Yeah.
So 2 points there. One, thank goodness you didn't spend the money until we got the genetics to find out that that wasn't the right thing. That's the benefit of getting this testing done, is you're not wasting time on the wrong drug for sure. And back to the fiber thing, I just want to say, given what you went through with that blockage, I 100% appreciate the panic that you might feel when you even think about starting to add more fiber to your diet.
Well,
right?
It's twice, December and May. Yeah, and so it's a terrible ordeal. Like you start vomiting, you vomit like 10 times. And you have to go to the ER. Yeah. And anyhow, it's an ordeal. So it's scary. And it could be a terminal event. So it's very dangerous.
It wouldn't be the first time we've heard of such a thing actually being the ultimate end of someone.
So when Alex says, I understand that I need the nutrition. Yeah. But it really scares me.
Yeah, well, this is it. You have this extra wrinkle that means that the ideal protocol isn't quite right for you at this time. But why I'm circling back to that is because based on this most recent CT scan, if the next one looks the same, I think you can breathe a sigh of relief and have more confidence adding fiber back. Because if this CT scan shows the resolution of that blockage, if I'm you, I want to see it again for sure. Absolutely.
It's not something that you can just take a chance on.
No, that's just why I really want to validate that for you, that even though the guidance is fiber, and Alex is saying the most recent CT scan shows clear, and we're thrilled about this. I too would want to just double, triple, quadruple check that this next scan looks very much the same, and then maybe start small. You know,
Well, I can start, like you mentioned earlier, I have a magic bullet and I can put in spinach and tomato, I can, that's a baby step,
yeah, that's
right? I can
yeah,
do
I'm gonna
that.
stick with those for a good long time. Given
Yeah,
again, it's not even so much about the CT scan at that point. If it shows clear again, then we know that's not a problem. It's about the appropriate psychological trauma, right? Like you just don't want to put yourself through that again. And I 100% agree. So until it's really obvious and you start small and it feels safe, I would do exactly the same thing. I go
thank
out.
you for the reassurance.
Yeah, 100%.
Yeah.
Yeah. Yeah.
I guess one other thing to be aware of is, in my case, all treatment drugs will fail. Like Alex has explained that to me, because cancer is smart, it mutates
Mhm.
and it finds a way around. And just to be aware of that and don't be shocked or
Mhm.
surprised, but then with that knowledge, plan accordingly. Okay, so when the fulvestrant fails, and that's why, Alex said, oh, well, there are new forms of fulvestrant that I can then move to, right? So then know what's next, because nothing worse than not having the required information. Like now what happens, right?
Right. Yeah. How it's
Yeah.
very scary to be thinking this is it.
Yeah.
Now
So
you
if
know,
you know that it is going to fail, then you
Yeah.
can prepare.
dial in a couple of options as you have. Exactly. And you can just go back to the well of all that genetic data that we have
Right.
to identify the next thing. And as Alex mentioned, those antibody drug conjugates, perhaps. And, there's just so many options. And every month there's
I
just
know.
new things.
And it's fascinating. Like it blows my mind when he explains some of that to me. I'm like, wow.
Yeah.
It seems so futuristic, but it's here.
Exactly. That's what's so exciting about this. So the combination of what kind of the balance of what the public healthcare system can provide for you, plus this precision cancer medicine testing, and then some assistance with the research and advocacy. That's I think the secret sauce right now.
Right. As a team, like a team approach. And I think that all cancer patients need a team, right? Like not just one doctor.
No, that's right. Because as you've seen in your experience,
as we've discussed, they can't know everything. They're not aware of everything.
yeah.
And so
Mm.
I hope that what I've shared as far as advice for new patients will be helpful. As I mentioned in the beginning, rather than starting way down here like I did, you can start where I'm at now,
Yes.
right?
Yeah.
And have all that benefit.
That's right. Yes.
Yeah.
And not have to go through all those surgeries and all of the pain that you've gone through.
Well, and the research, right? And the lessons learned.
Yes. Yes. Well, this will be very beneficial to many people. I have no doubt, Gail. I am thrilled to be able, through what you have chosen to do and what you've allowed us to help you with, I'm thrilled that your doctor and the Mayo doctor now understand a few more things. And if that's an excellent outcome. What you're experiencing now, plus a little more education on the part of a few doctors, excellent outcome. But if we can use your experience to educate, hundreds of doctors simultaneously and thousands of patients, just imagine how much faster this will become a part of standard of care. And that's my mission, 100%, is that everybody gets what you got at the start.
Exactly. So that has been one of my goals all along. And I even asked my oncologist at my last appointment whether he would consider doing a case study, because that's where I've derived a lot of my information, or basis for questions to ask is reading case studies online. And so I thought, well, because if you do granulosa cell tumor search, not much comes up, but if my case study came up, that would be helpful. And he said, yeah, we would do a case study, but not until after you're dead, because that's the full story. I said, okay.
Wow.
They tell it like it is, right?
Yeah.
And so that was on Tuesday, the 21st, I had an appointment with him. And then I talked to Alex on the 23rd. He's like, oh, absolutely, we'll do a case study. Not only that, can we interview you? Like he was just in the moment, which is what I want. Why wait to share the information?
That's right. Yes.
Yeah.
Yeah, exactly. So we'll make sure it gets out there now. And then if he does do his case study years down the road,
Yeah, yeah.
you know, we'll
I
circle
know,
around
but I
then.
just have to laugh because, that's
Yeah.
the animal. That's how they are.
That's it, exactly. It tells you a
Yeah.
lot about their thought process.
Yeah.
Absolutely. Yeah. Whereas, yeah, I love your thought process, and ours is the same as who can we help now? And
Yes.
how can this information be applied and benefit people now? So thank you so much, Gail.
You're welcome.
You've been,
It's been so nice talking to you.
thank you. You too. Yeah, we've had lots of
Thank you.
emails back and forth,
Yeah.
but never a chance to really have a good chat. So
Yes.
I'm just thrilled with how things went. You were an excellent self-advocate. That is, I mean, Alex is phenomenal. What he's done for you is great. What his team has done is great. They're miles ahead of the rest of the world. Absolutely 100%.
Mhm.
And you found us. You did the research. You advocated well for yourself. And that's why you're here in the condition that you are. So congratulations.
Thank you, Michelle. I've worked hard, and thank you for the compliment.
You're welcome. You're welcome. It's really nice to speak to you.
Nice talking to you too. Have a Merry Christmas.
Thank you. Bye.
Thank you. Bye now.